Okay, so let's review some of the key concepts for this first part of the Hashimoto's course. So the key thing is that most people that have Hashimoto's don't come in with overt hypothyroid symptoms. The symptoms are just general brain fatigue, a little bit of depression, reduced brain function, poor brain endurance, some chronic constipation issues, and they just don't feel well. And one of the key things that you want to make sure you understand is that the Hashimoto's thyroiditis autoimmune response takes many, many years before it leads into hypothyroid. Some of the most chronically sick and challenged patients are ones that have never been diagnosed in hypothyroid and won't be for many years because they don't have enough thyroid gland destruction, but the autoimmunity is there, and the autoimmunity is causing this chronic inflammatory cascade. So remember that autoimmunity has 3 stages. Stage 1 is silent, where they just have antibodies and no symptoms. And this is something you also want to know when you're looking at family trees. Many times when you're in practice, you'll have patients come in and you'll do a great job and they want you to see their family, and they want you to see their kids, they want you to see their brother or sister. The minute you know that Hashimoto's exist in a family gene pool, you definitely want to check other people. So you could be working with a mom and you want to check the 14-year-old daughter and see if they have antibodies yet or not. And some of them have silent autoimmunity, so they know that this can progress into autoimmune reactivity, which is where they have elevated TPO antibodies, but their TSH is normal, and then further into actual Hashimoto's autoimmune hypothyroidism, where enough of the gland is destroyed in stage 3, where now they're finally diagnosed in a thyroid disease. But that whole process takes many, many years. As pointed out with this great diagram in this paper published in the European Society of Endocrinology, they show that in early stages this progresses, and the first thing that shows up are antibodies. But even another paper that I showed you show that the cytotoxic changes take place in biopsies way before they show up in blood, that a third of people that there's a threefold increase in people that have cytological change in the thyroid gland before they actually even start showing up with antibodies. So be aware of those changes. And by the way, there are some patients that have all the symptoms of Hashimoto's, hypo, mixed symptoms, fluctuating, instability, chronic inflammation, and they never test for antibodies. And sometimes if you just get them out for a biopsy, the biopsy will confirm they have Hashimoto's thyroiditis. So that does exist as well. Now, if you look at the research, they found that the time for first showing up antibodies, which you see here, into actually developing hypothyroid, on the average was 7 years when they look at the composite score for multiple papers published on this in the journal Autoimmune Reviews. So we know that that is a key factor. Also remember, an important concept we talked about was that TSH levels go up and they go down, and they go up and they go down. And when patients have an autoimmune flare-up and the thyroid gland gets destroyed, their TSH can go down. And when their thyroid gland is not able to produce enough thyroid hormones, then TSH levels go back up, and they go back down, and they go back up, and they go back down. So there's a high level of fluctuating TSH levels, especially between stages 2 and 3 in the autoimmune response. So sometimes it's better just to measure the antibodies. And if you measure the antibodies, your TPO antibodies are the ones that are more likely to show Hashimoto's. In some studies, it was 96% showed up with TPO antibodies, and only 80% showed up with thyroid globulin. So TPO would be a really good screen to just use in your practice. Now, a key concept we talked about was TSH levels can fluctuate with relapsing and remitting autoimmune reactions against the thyroid gland, leading to the alteration, states of tissue breakdown, and change of circulating thyroid levels, and screen for Hashimoto's by testing TPO and thyroid globulin antibodies. It should be something you consider as part of your routine panel with your patient population, because you're going to be surprised how many people actually have Hashimoto's thyroiditis. Now, in the early stages of Hashimoto's, thyroid levels of TSH, T4, T3, free T4 typically normal. So again, screen for those antibodies. And for those of you that listen to the seminar, think about when's the last time you checked your own antibodies? And especially if you're a female, aged anywhere between 30 to 60, you may have not even known you've had Hashimoto's turn on until you get checked. So remember that for a lot of people that have Hashimoto's, their genes don't express into it until they're starting to get to the midline range of age 40. And then that's when they start to feel a little bit older, but it may not be the fact that they're older, just maybe the fact that their metabolic rate has come down. So be aware of that. Now, another important concept we talked about was this over-reliance on TSH is getting many patients to be not diagnosed with these fluctuating levels of TSH that are taking place. And many patients will really fall into this trap where they have Hashimoto's and they never get tested properly, so they never get the diagnosis. So be aware of those factors as well. And I also want to point out something else here. You have to realize with many Hashimoto's patients, their TSH levels would come up, go down, go up, go down, go up, and go down. What if you decided you were going to do some kind of esoteric therapy? What if you were going to give someone some random, I don't know, homeopathic solution or some random mineral or some, I don't know, any kind of therapy, and you saw them go from a high TSH down to here? Did you make them better? Who knows? Maybe it was just a normal response. Maybe it was actually a flare-up. So that's one of the things you have to take into account, is that they're not always getting better. Now, the biggest clue that a patient's getting better or worse if they're having their TSH levels drop was that drop in TSH accompanied by symptoms of hyperactive response, like inward trembling, nervousness, anxiety, increased bowel movements, increased motility, digestive disruption. And if it occurred, then it's most likely a flare-up and not that the patient is getting better. Okay. Now, one of the other key things we talked about was the concept of when you're looking at Hashimoto's in the normal thyroid physiological pathways, we have three main areas of assault. One is the immune system is constantly destroying the thyrocytes. Two, the chronic inflammatory response in Hashimoto's is having a significant impact in the conversion of T4 into T3 pathways. And at the thyroid receptor site, thyroid hormones may not respond just because of the chronic cytokine and inflammatory load. So sometimes you can't really get any significant change in your patient's thyroid function until the entire inflammatory load comes down. And we ended the introduction with this concluding slide that said the most common reason practitioners fail with Hashimoto's patients is that they don't understand the disease, so they do the following. They create unrealistic expectations, they develop linear protocols, they don't understand that the disease can express differently at different times, so they get confused and freaked out when the patient has different responses, so does the patient, and they're unable to educate the patients on these concepts. So we spent a lot of time in this part one of the course really going over the web and the pathophysiology, and then we started to get into diet, nutrition, lifestyle just a little bit before we get into a comprehensive approach. Now, we went through different webs and different mechanisms involved with Hashimoto's, and the immune web is a really important one. So you have to understand that just the single fact that someone comes in with the diagnosis of hypothyroid, it's most likely Hashimoto's, 90% or greater chance. And then if it is Hashimoto's, it's not just a thyroid disorder, and you would expect that to some degree, all Hashimoto's patients would have decreased antioxidant production, antioxidant levels. Studies show that. They're more prone for oxidative stress. They have some degree of brain inflammation. Their tight junctions are going to be compromised. They're going to have intestinal permeability, and they're going to have some dysregulation of their immune system. And this is all kind of in a vicious cycle. So the model of going autoimmunity or Hashimoto's is caused by just leaky gut, if I just fix leaky gut and I can fix this, is a failing model. And the model of just assuming that you give someone anti-inflammatory compounds will have an effect is also a failing model, because you could have the autoimmunity constantly being triggered by environmental triggers or food triggers, and they're constantly depleting their antioxidant levels. So be aware of all these different mechanisms that are involved. The most worrisome and complex pattern of Hashimoto's is the impact of Hashimoto's on the brain. I mean, Hashimoto's devastates the brain. I mean, it probably devastates the brain more than devastates the thyroid gland. The antibodies for the thyroid gland, TPO, directly connect with the cerebellum. I bet you if they found these TPO antibodies in cerebellum patients first, they would call these cerebellum antibodies, and it would be the opposite. They would go, these cerebellum antibodies also attached to the thyroid. It just happened that they found these thyroid antibodies first, but these TPO antibodies bind to the astrocytes in the cerebellum. That's cross-reactivity. And many patients have Hashimoto's also have the genes for either celiac or gluten sensitivity, and gluten has been shown to bind to the cerebellum. So there's significant cross-reactivity with gluten and TPO antibodies, which really creates this vulnerability for increased cerebellum destruction. Then you combine that with chronic inflammation of the brain through the cytokine activation of glia and blood-brain permeability, and you have a recipe for neurodegeneration, especially cerebellum degeneration. So as we get into part 2, it's really important that you understand how to evaluate the cerebellum from history and physical exam, and then what kind of treatment interventions you need to do to really rebuild and regenerate that cerebellar system. You should also really make sure you understand all the concepts of neuroinflammation. We made an entire clinical module on neuroinflammation, and those concepts and approaches can also be important for some Hashimoto's patients that have ongoing neurodegenerative symptoms. For example, they have a traumatic brain injury, their glial cells get primed, then years later they get Hashimoto's. You figure out how to calm down the Hashimoto's, but their neuroinflammation and their primed glial cells are still a part of it, and as their Hashimoto's flares up, they get that continued inflammatory cascade. We also know that when people get Hashimoto's, they have significant changes in their neurosynaptic activity and branching, so their ability to preserve their brain function, new skills, and optimize their brain as years come up become compromised. So you see Hashimoto's patients, they just stop taking new tasks. They don't do new things. They kind of just go through life with what they can tolerate and what they can manage, and their human potential is compromised. We also know there's lots of tissue swelling that takes place. So you get things like thoracoatlas syndromes and carpal tunnels and ulnar tunnel syndromes and peroneal nerve entrapments and all different types of tissue swelling nerve entrapments in the peripheral nervous system. Now, the web of Hashimoto's, when we get into the gut, you just have to know motor complex activity in the gut's compromised. So they can't activate their gut, they can't activate the gallbladder. The microbiome is compromised. There's lack of diversity in the gut. There's a tendency for dysbiosis. And many people with Hashimoto's also have intestinal autoimmune responses and celiac issues. So that's part of the picture. So as soon as you see the diagnosis of hypothyroid on chief complaints or previous diagnosis in your new patient's file, you should know that there's a lot of things happening in the gut with these patients. One of the most overlooked areas that we talked about with Hashimoto's patients is blood sugar control. Drops in blood sugar like hypoglycemia or insulin resistance are major immune activators for Hashimoto's. One of the most common overlooked pathways where Hashimoto's patients can't get better because their blood sugar roller coaster ride is never really managed. And then there's intimate connections between the liver and processing thyroid hormones and making binding proteins and clearing chemicals and compounds that are important for Hashimoto's, as well as impacts on the female endocrine feedback loop systems and different receptors. So ultimately there's a web. And within this web, we're going to start getting more into triggers. We talked about some triggers so far in part 1. We talked about iodine, we talked about gluten, we talked about lectins, we talked about cross-reactive proteins. We talked about how sodium can be a trigger to this web, lack of microbiome diversity, but we covered pretty much the things you see in yellow. Those are things that we covered so far, but we have to cover all these blues and greens, and we'll get into those more as we get into part 2. Now, we know that every Hashimoto's patient has different impacts and triggers on this web. So, for example, you can have a patient that has Hashimoto's, but they have excessive chemical burdens, or they're on oral contraceptives in combination with having celiac and taking iodine in their daily routine. And these things are going to impact this web more than in certain areas than other areas and cause different triggers, and they'll need a different unique protocol to make a difference for them. So remember, we didn't really discuss any protocols, and we're not going to discuss any specific protocols. We're going to just understand the mechanisms, the physiological responses, and try to put these things together for you. And remember, the key thing between an experienced and novice practitioner is an experienced practitioner can take a step back, look at the whole picture, and then apply an approach. When it comes to what we're going to do in part 2 of this course, my goal is to teach you how to evaluate the patient, take the checklist, mark off all the pieces of the checklist which apply to all the different webs, have a priority of where to start, see the big picture, take a step back, and then figure out where you want to pull on the web first to make the biggest difference. Now, that comes more to a personalized approach. We did cover in part 1 dietary, nutraceutical, lifestyle, and hormone replacement triggers. We talked about dietary restrictions versus dietary modifications, and we went into how insulin surges impact them, and we covered how different nutraceuticals have different effects on the thyroid, and then we went over how important thyroid hormone replacement is and the different decision processes, different decisions you have to make to identify the thyroid hormones. So all of these are all part of figuring out how to develop the best protocol for Hashimoto's patients, and those are the main concepts for part 1.